Good afternoon, everyone, and welcome to the Virginia Chiropractic Association's webinar on chiropractic best practices, understanding the CCGPP guidelines for low back pain treatment. My name is Lisa Majeski West, and I am the founder and president of Gold Star Medical Business Services. I am thrilled to be here today presenting on behalf of the VCA and the CCGPP Clinical Compass. And so we're going to get started right away. We have a lot of material to cover this afternoon. So without further ado, what I would like to just remind you of is if you do have any questions during the course of the webinar, you can type your questions into the chat box in the menu of the GoToMeeting link that you have, and feel free to put down any questions that you have. We will have a Q&A part at the end of the webinar today. Hopefully we'll have enough time for it. I know that I do have a lot of material to cover, but I'd like to try and leave about 10 minutes towards the end of the presentation for any questions that you might have that will arise out of this lecture today. So without further ado, let's go ahead and get started on the chiropractic best practices for understanding the CCGPP guidelines for low back pain treatment. We're going to be recording this session today, and so if at any time during the webinar you have to step away or something happens and you have to leave the webinar early, don't fret. We will have this webinar recorded for you so you can listen to it at a later time. And I will be providing Pam or Julie the link for the webinar. So, okie doke. Let's go ahead and get started. The first thing I want to do is just tell you a little bit about myself. Again, my name is Lisa Majeski West, and I am the president of Gold Star Medical Business Services. I've been out in the chiropractic field for a long time. I started working in chiropractic 36 years ago. In 1982, I took my first job as a CA working in a chiropractic office in New York City while I was going to school, and I was in college at the time. And throughout many years, actually, I worked in a variety of different medical and chiropractic offices. And in 1994, my husband, who was in the military, was stationed in San Angelo, Texas. And at that time, I became the clinic director for a group called Lone Star Chiropractic Clinics. Was there with them for 5 years, and we had a lot of fun managing a very large multi-specialty clinic. He had multidisciplinary practice, and we also did satellite clinics together, and so I was doing quite a bit of traveling. In 1999, I had a little surprise come into my life, and my son is now 18 years old. So at that time, I decided that it was just really too difficult for me to maintain the job as clinic director of the main practice and the other 4 satellite clinics. So I decided to step down from that position. And at that time, the owner of the clinics was a member of CATS Management, which is a practice consulting group that has now been sold and is renamed Integrity Management. So many of you may know this group as Integrity Management, and I was with them for 10 years as a practice consultant. They hired me on after I left Lone Star Chiropractic Clinics, and I went out and spoke at seminars for years with them, teaching both DC and CA classes and consulting with chiropractors all throughout the United States on ways they could build their practice. And during the period that I was tenured with them, I founded a company, Gold Star Medical Business Services, and essentially what we did was I started a company as a way to provide a job for my husband, who was at that time disabled. And he could no longer work outside the home and had a progressive neurological illness that prevented him from having a regular job, had a lot of doctor's appointments, and the illness itself was very much like MS, so he had good days and bad days. And so we came up with this crazy idea to teach him how to be a billing CA and I taught him all about chiropractic coding and billing, and we found a doctor who needed billing services, and the company was off and running. And so over a period of a couple of years, word of mouth began to grow the business, and within a couple of years we had 8 doctors that we were doing billing for, and we began to hire other family members to help out. His mom started doing pay posting, and my daughter started doing insurance verifications, and so it really became a family cottage business. After a couple of years, in 2009, my husband passed away, and at that time I really needed to decide whether this was going to be a situation where I was going to stay with my job at Integrity Management or leave and run Gold Star full time. And I decided to take the leap of faith and run Gold Star full time. So I'm not sorry that I did that. We have grown since the beginning of 2010 into a company where we have over 60 clients who we do both billing and consulting with. And we not only work with chiropractors now, I've branched out, and we work with medical doctors and other medical specialty offices. So we do behavioral health billing, we've done dermatology, pediatrics. So there's a number of different medical specialties that we now do billing for. I've also received some certifications through these last 7 years to really develop my skill set to a much higher level. One is the MCSP, which is a Certified Medical Compliance Specialist with additional chiropractic specialization. And I'm also a Certified Medical Coder, Certified Medical Office Manager, and Certified Medical Insurance Specialist. And in my spare time, I'm also on the faculty of an organization and the director of chiropractic program development for an organization called Practice Management Institute. And I have 5 children. I'm now in a blended family. I remarried, and we have 1 child still at home. I've got 4 grandchildren, and I'm a certified yoga instructor and love to teach yoga classes. And so that's who I am. Hopefully that will give you a little bit of a flavor of the person that is instructing you today. And so what we're going to be talking about in this webinar is what I call the age-old question in chiropractic. And over the years, as a practice consultant and also as the owner of my own billing company now, I very oftentimes will be asked the question, how many visits can I get from this insurance company? How many visits will this Blue Cross plan pay for? How many visits can I treat this patient before I need to do a pre-authorization with United Healthcare or with ACE or with Ashen? If I can only get 5 visits, then once I'm past 5 visits, I'm just going to push the patient over to maintenance and make them pay cash. Does Medicare cover? How many visits does Medicare really cover? I've heard that there's this 12 visit cap, and they won't cover any more than 12 visits. How many visits do I have to do before I have to do a re-exam? Should I do a re-exam every 3 months, or should I do a re-exam every month or every 12 visits? When do I need to do a re-exam? Or do I get any extra visits under PT benefits? I know, but I just got this insurance verification, and it says that I have 12 visits for chiropractic and I have 20 visits for PT. Does that mean I can do more PT visits and stop treating the patient under chiropractic? How many visits do you think this patient can afford? I mean, as a cash patient, I don't know. I think I'll just give them 6 or 7 visits and then cut them loose to maintenance, because they're a cash patient and they're self-pay. Maybe they can't afford, 36 visits like I would normally recommend. Or better yet, what about my practice management consulting group? I've got a practice management consulting group that says I'm supposed to schedule everybody for 36 visits and they're all supposed to prepay. Or I'm supposed to schedule patients based on Mercy Conference guidelines or this guideline or that guideline. And so my practice management consultant is telling me to schedule for X number of visits. So there are all kinds of ways that chiropractors will ask me the question about how many visits. It's that age-old question. How many visits can I get from a patient before they have to start paying out of their pocket? And let me just pose this to you. What if the question really was this? How many visits does my patient need based on their individual presentation of symptoms, past medical history of musculoskeletal and or neurological conditions, and based on the scientific evidence? And where can I find the science behind it? So let's talk about one of the premier sources of the scientific position papers for the chiropractic profession, and that is the Clinical Compass. Clinical Compass is a nonprofit organization that is the gatekeeper, so to speak, for the Council on Chiropractic Guidelines and Practice Parameters. And the CCGPP has been in operation for many years. They were formed in 1995 at the behest of a wide group of chiropractic associations and colleges and foundations that were looking to find a place where the science of chiropractic could be distributed, researched, vetted, and maintained. And the CCGPP took up the helm of this, and basically through extensive and exhaustive research, through panels, and through ongoing updates, including both doctor and public comment, they began to develop a series of guidelines to assist chiropractors with patient case management and care management of different types of chiropractic patients. The CCGPP is charged with researching and rating the evidence, which is then compiled into a summary document for the chiropractic profession and other related stakeholders. And many insurance carriers look to the CCGPP as their standard for medical necessity for insurance plans and for chiropractic benefits under certain insurance plans. And as you'll see, Medicare follows very closely and aligns very closely with the CCGPP guidelines. I'll be showing that to you here throughout the presentation this afternoon. The 8 clinical chapters covered in the project assembled is called a literature synthesis, and basically this literature synthesis is going to provide scientific literature to support the treatment parameters that you are recommending for your patients. Everything that I'm going to be talking to you about today, as by way of disclosure, comes directly from Clinical Compass or from Medicare. I am not one of those instructors that injects a lot of opinion into my presentations. I like to look at the facts, the evidence, and the science, and I will always have a source for just about everything I say. And if it is my opinion, I will tell you that it's my opinion. But for the most part, we're going to be talking directly to the CCGPP guidelines for treatment of low back conditions. And so before we get into the actual guideline itself, I do want to talk about the difference between a guideline and a best practice, because I think sometimes there's a little bit of confusion on that. Now, a guideline is a document that contains specific numbers and suggested therapy timeframes that are often mistakenly applied as arbitrary limits. So sometimes what a doctor will do, they'll take a guideline and they'll say, okay, CCGPP says 12 visits, so that's what I'm going to do on every low back case. And that's really not what the guidelines are meant to do. Now, the best practice is a process and a document after the process that reviews the evidence and provides interpretation consistent with the chiropractic perspective, as the providers are involved in treating the cases using different chiropractic methods. best practices is more of a process and an initiative rather than just a document. The best practice initiative, which the CCGPP is developing right now, contains 3 elements: the research, the clinical judgment, and patient values. And as Dr. Wayne Bennett he's one of the board members of the CCGPP, this was his quote. He said, "Chiropractic best practices bring the chiropractic philosopher healer, the skeptic researcher, and the pragmatist practitioner together on common ground to meet the needs of the chiropractic patient in the best possible manner." And so the best practices are ways to take the guidelines and incorporate them into treatment parameters for your patient that are in the patient's best interest. And so let's talk about the actual CCGPP guideline, chiropractic care for low back pain. It was published, the last revision of this guideline was published January of 2016 in the JMPT, the Journal of Manipulative and Physiological Therapeutics. And the objective of this guideline was to provide an update of a previously published evidence-based practice guideline on chiropractic management of low back pain. The project updated and combined 3 previous guidelines, and a systematic review of articles published between October 2009 through February of 2014 was conducted to update the literature published since the previous CCGPP guidelines were developed. There was a Delphi panel of 37 panelists who participated in this most recent update, 33 of which were doctors of chiropractic, and the other 5 were other medical specialties, such as acupuncture. There was a massage therapist, I believe, and some MDs that were also involved. Maybe, I think, a physical therapist as well. I don't know that for sure, but if you go through the guideline and look at the Delphi panel, it will tell you who participated. But the bottom line is it gives you a good cross-section of research. So this isn't just coming from the chiropractic profession. The medical profession, PTs chimed in on these guidelines. Consensus was reached on the guideline after 1 round of revisions, with an additional round conducted to reach consensus on the changes that resulted from the public comment period. So after the revision was done, then it was open for public comment, meaning you as a chiropractor were able to comment on the guidelines, on what you agreed with, what you disagreed with, what you may have found to be confusing about the guidelines or wanting clarity. And then another revision was done after this public comment. Most of the recommendations made in the original guidelines were unchanged after going through the consensus process. And the bottom line of the guidelines is that the evidence, the scientific evidence, supports that doctors of chiropractic are well suited to diagnose, treat, co-manage, and manage the treatment of patients with low back pain disorders. Now, I know that I'm preaching to the choir here. I'm probably speaking to a group of chiropractors and only chiropractors, or maybe some chiropractic assistants. And I know that having been in the field as many years as I have, when I read that, I thought, well, duh, yeah, we know that that's the case, and that chiropractors are not only well suited, but they are best suited to diagnose, treat, co-manage, and manage the treatment of patients with low back pain disorders. Now, some of the highlights, and we're going to talk about, and of course, the document is, I believe, 22 pages long. So in the short hour we have, we certainly don't have time to go through every line and every word of this guideline. So I do encourage you to read the guidelines from start to finish and make your own notes on elements of the guidelines that hit you, that you feel would be able to help you in your practice and in the management of your patients with low back issues. So under the guidelines, one of the things that was brought out is that the traditional approach in which a trial of natural and less invasive methods precedes aggressive therapies has gained credibility. So the medical profession recognizes that a trial of chiropractic care could very well prevent a patient from having to have a surgical procedure or having to be on drugs, pain management or drugs. And of course, with the opioid addiction and the issues that we are having as a country with the epidemic of opioid addiction, healthcare practitioners and organizations are looking for ways to help patients better manage their musculoskeletal pain, because musculoskeletal pain is one of the leading causes of opioid prescriptions. And so it has gained credibility, but the chiropractic profession can actually gain wider acceptance in the role as the first point of contact healthcare providers to patients with low back disorders, particularly within the integrated healthcare delivery systems, by embracing the scientific approach integral to evidence-based healthcare. And look, I work with medical doctors extensively as my tenure on the faculty of the Practice Management Institute. The Practice Management Institute has been, up until the last year or so, 100% medical, no chiropractic whatsoever. And so I have actually been out teaching coding and documentation and compliance to medical facilities, hospitals, multi-specialty clinics, everything but chiropractic, okay? And I'm able to have wonderful conversations with these medical professionals, and whenever I can engage with a doctor, an MD or an osteopath or a nurse practitioner or a PA, I'll try to take the conversation around to chiropractic care and ask them what their opinion is of chiropractic. And, what I'm finding is that from the time I started 36 years ago, there's a lot more general acceptance of chiropractic. There's not as much antagonism toward the chiropractic profession. But one of the things that I hear throughout my conversation, and it threads throughout the entire medical profession as I speak to medical professionals about chiropractic, is that they wish that the chiropractors would participate more in the co-management of their patients by providing them with regular updates to a patient's care that maybe they are treating that is under the primary care of this family practice doctor or whatever. And they say that many times their beef with chiropractors is that they will send a patient over to the chiropractor, and then the patient, they don't know what the outcome of that chiropractic treatment is, and they say that never happens to them when they refer a patient out to another specialist. So if they refer a patient out to a dermatologist, that derm report, on whatever, let's say they did a biopsy on some lesions, that dermatologist is going to immediately send the results of that biopsy over to the patient's primary care doctor. And chiropractors are in general, not everybody of course, but in general, really deficient at that, really deficient at keeping the primary care doctors in the loop. So, one of the things that the CCGPP guidelines points out is that they recognize, doctors of chiropractic, that a variety of healthcare providers play a critical role in the treatment and recovery process of patients at various stages, and that DCs should consult, refer patients, and co-manage patients with them, meaning medical doctors or the mainstream medical community, when in the patient's best interest. So let me ask you this question as we're pondering this. How would you rate your relationship with other members of the medical profession in your community? Do you have good relations with medical doctors? Do you receive regular referrals from medical doctors in the community? And do you refer back to them? Later on in this presentation, there's going to be an area in the CCGPP guidelines that discuss contraindications to chiropractic treatment. And so, I've been in the chiropractic field long enough that maybe 5% of the patients that come into a chiropractic office, and in some cases it might be even more, but a percentage of patients that come to see a chiropractor don't need to see a chiropractor. They need to be referred out. And the question is do you easily and willingly make that referral over to a medical doctor? Now, I totally understand the reasons why you might not, okay? Because just like the medical doctor will feel as if they never hear back from their patient when they go see the chiropractors can complain about the same thing. They'll say, well, I send my patient over to a medical doctor, and then I never see the patient again. The doctor tells them not to come back. And that's very valid, and I totally get that. But I think if you begin to develop and cultivate trusting relationships with certain doctors or healthcare practitioners in your community, you'll be more likely and more willing to refer back and forth. So one thing that you might want to do just to even get started with this process, if this is something very foreign to you and you don't normally refer to the medical profession in your community, you might just include on your patient intake forms a place for the patient to write down the name of their primary care doctor, the telephone, and whether you may contact that doctor or no. And if the patient says yes, you may contact, then you may want to get into the habit of anytime the patient has a medical doctor listed on their intake form, you, as just routine, whether it's asked for or not, you begin to send a report to that medical doctor, to that patient's doctor, and maybe even send a report of the updated re-exam, send a radiology report if necessary, but send them something to let that doctor know that you are now co-managing that patient's care. And I'm just going to tell you a really interesting story about this because it happened recently to one of the doctors that I was doing a consulting with, and it has happened to me as well personally when I was working as a CA for a chiropractic doctor. This patient came to see the doctor and was referred by an MD in the community that never refers to chiropractors. And so when this patient showed up at the doctor's office, his jaw dropped, and he basically said, was curious and asked the patient, I see that Dr. So-and-so referred you to me, and I'm just going to be honest with you, he's not usually very receptive to referring people to the chiropractor. We've had some issues in the past. And the patient said, oh, yeah, I know. He did not want to refer to you. And the doctor said, okay, well, that's the doctor that I'm thinking about then. And so the patient said, but, and so the doctor asked the patient, well, how is it that he made the referral? And so this patient said, well, I've just moved into town and I've seen a chiropractor all my life. And I went to my medical doctor for my annual physical and I asked him for a referral. And he said, I don't believe in chiropractors. And the patient said, well, that's okay. You don't have to believe in them, but I need a good chiropractor. Do you know of anybody? Or should I go somewhere else for a referral? Because I'm going to go see a chiropractor. And the doctor said this. He said, well, I tell you what, if you really, really are insistent on going to see a chiropractor, go see Dr. So-and-so, because even though I don't believe in chiropractic, I know that he's going to take good care of you, because when he does see my patients, he sends me reports and lets me know what he's doing. So I trust that he's not going to do any harm to you and whatnot. And so this doctor still didn't believe in chiropractic, but didn't hesitate then to refer to the doctor who kept him in the loop about his patient care. And so enough said about that, but I really do believe that one of the highlights of the CCGPP guidelines for treatment of low back pain is to allow yourself the freedom and be willing to co-manage patients in a multidisciplinary setting. So let's talk about, under the CCGPP guidelines, what those treatment frequencies and durations for trials of chiropractic treatment are. And the CCGPP guidelines refers to chiropractic treatment plans as trials of chiropractic treatment. And they basically break it down into 4 scenarios. You have the acute and subacute patient. You have the patient who may have a recurrence of previously treated condition or a flare-up, or a flare-up could also be called an exacerbation, a chronic condition or an exacerbation. And based on the presentation of the patient and where they're at, whether they are acute, subacute, chronic, exacerbation, there are recommendation of numbers of visits per week per how many weeks of treatment. And so you will see that under the acute and subacute, it's 2 to 3 times a week for 2 to 4 weeks. And you can see that it's a very ambiguous number. They're not saying 18 visits 3 times a week for 1 week, 3 times a week for 2 weeks, twice a week for 2 weeks, and once a week for 2 weeks. They're not saying that. They're saying 2 to 3 times weekly for 2 to 4 weeks. If it's a recurrence or a flare-up, 1 to 3 times weekly for 1 to 2 weeks. A chronic patient, 1 to 3 times weekly for 2 to 4 weeks, and so on and so forth. And you can read through these, okay? But one of the things that you do need to remember is that these are not hard numbers. So you cannot take this and just cookie cut it into your practice and say, all right, I'm going to take the 3 times a week for 4 weeks, and that's going to be my acute and subacute care plan. And I'm going to take the chronic patient, and it's going to be 3 times a week for a week, 2 times a week for a week, and once a week for a week. And that's going to be my chronic care. You must take this on a case-by-case basis. And the guideline specifically says that an individual patient may be best served in subsequent trials of care by treatment that is highly personalized to their own mechanical disorder, experience of pain and disability, as well as preference for a specific treatment approach. This is consistent with the 3 components of evidence-based practice or best practices: clinician experience and judgment, patient preferences and values, and the best available scientific evidence. So again, remember that these are guidelines and not hard limits. So in the guidelines, CCGPP very clearly defines the 4 stages of illness and injury as acute, subacute, chronic, and recurrent or flare-up. An acute condition is one under CCGPP guidelines of where a patient has had symptoms persisting for less than 6 weeks, subacute between 6 and 12 weeks, chronic conditions at least 12 weeks of duration, 3 months essentially, or recurrent flare-up is a return of symptoms perceived to be similar to those of the original injury at sporadic intervals or as a result of exacerbating factors. So throughout the guidelines, one of the things that you're going to see is that there is strong emphasis on documentation of patient outcomes and functional improvement. Chiropractors love to sit in pain, okay? Even though a chiropractor is not a pain doctor, they are typically they are and should be considered functional doctors. Many chiropractors will use the pain diagnosis codes and pain as a basis for treatment, sort of as a catch-all or as a crutch, if you would say so. And one of the things that I've seen over and over and over again as a biller, working with many different chiropractic offices, is that the majority of chiropractors, and I'm not going to say everybody because there are some that have got this cold. I mean, I can be, hopefully you're listening to this and all you're doing as you listen to this is patting yourself on the back and saying, wow, I'm doing great because this is exactly the way I'm treating patients. But I'm just going to say, and we can all take our halos off, but that this isn't the majority of chiropractors. Unfortunately, the majority of chiropractors love to live with 3 codes as their diagnosis codes, which are cervicalgia, dorsalgia, and lumbalgia, and use those 3 codes for 30 visits, 35 visits, 40 visits, and expect that an insurance company is going to continue to pay for those. And on audit, and sometimes they do, but then on audit, all that money gets taken back because there was not any emphasis on function and functional improvement of that patient. So we're gonna land here for a few minutes, and we're really going to talk about this because not only do the CCGPP guidelines strongly emphasize improvement in function as one of the mainstays for justifying medical necessity in a chiropractic treatment plan, but so does Medicare. And so at the bottom of your screen here, it will actually, this is actually comes from the Medicare LCDs for chiropractic services, of which our 3rd webinar in this series is going to be 100% on Medicare and Medicare treatment parameters and guidelines. And so one of the things that the CCGPP says is for acute and subacute stages, up to 12 visits per trial of care. If additional trials of care are indicated, supporting documentation should be available for review, including, but not necessarily limited to, documentation of complicating factors and/or comorbidities. So what would that be? What would a complicating factor or comorbidity be? A complicating factor might be the patient's job. Maybe they're in a job in which they are continually doing heavy lifting, and so they are always exacerbating a low back problem. Comorbidities might be a patient who is morbidly obese, and because of their obesity, they are going to continue to have chronic back problems until they can lose some weight. So comorbidities need to be documented as a reason for a patient needing ongoing care under either acute, subacute, or for that matter, chronic conditions. And then coupled with evidence of functional gains from earlier trials. Efforts towards self-care recommendations should be documented. So how would you grade yourself in documenting functional improvements of your patients? Medicare says, and you'll see this at the bottom of your screen, the patient must have a significant health problem in the form of a neuromusculoskeletal condition necessitating treatment, and the manipulative services rendered must have a direct therapeutic relationship to the patient's condition and provide a reasonable expectation of recovery or improvement of function. And you'll see the words function all over the Medicare LCDs for chiropractic services throughout all of the Medicare administrative contractors that do contract billing for chiropractic services. So let me ask you this question. Under the acute care pain management of your patient, are you doing a reevaluation on or around visit 12 and adding a trial of care beyond those 12 visits that would be supported by a baseline functional assessment and that are supported by visual and measurable improvement in the patient's function? Are you documenting comorbidities, and have you discussed self-care options with the patient and documented these discussions that you've had with the patient about self-care options? Let me ask you this. Now we talked about the acute care patient on our last slide, and this slide really deals with the chronic care patient, and the CCGPP guidelines dedicate several pages of literature to the treatment and management of a chronic care patient. Why? Because we see a lot of chronic patients, and we, as a chiropractic profession as a whole, this is probably one of the most difficult types of patients to prove medical necessity for ongoing treatment. Yet, Medicare does recognize a chronic subluxation as medically necessary for treatment under the Medicare program. You can treat patients using an AT modifier if they have what is defined as a chronic subluxation. These are your patients that return to your office every 2 to 3 weeks. They can't even go a month, without having to see you again. But the thing is what are they using chiropractic care for? Are they using chiropractic as an aspirin, okay, to relieve some aggravating back pain, or is the fact that they're having to come back every 2 to 3 weeks because there is a marked deterioration in their functional status and in their activities of daily living, or their ADLs, that warrant that treatment so they can get back up to their previously maximum functional status? And so, Medicare's definition of chronic is that a patient's condition is considered to be chronic when it's not expected to significantly improve or be resolved with further treatment, but where continued therapy can be expected to result in some functional improvement. You can't even justify medical necessity on a chronic patient without having some type of functional baseline and outcomes, because if you don't have anything in your documentation relating to the patient's functional status, then you're essentially cutting yourself off at the knees to becoming a pain management doctor for that Medicare patient, or really for any insurance patient, without the functional component of it. And it says here in the CCGPP guidelines, it mirrors almost what Medicare says, and it says that for chronic presentations, exacerbations, and scheduled ongoing care for management of chronic pain, additional care must, not may or should, but must be supported with evidence of either functional improvement or functional optimization. Such presentations may include, but are not limited to, the following: substantial symptom recurrences following treatment withdrawal, minimization, control of pain, maintenance of function and ability to perform common ADLs, minimization of dependence on therapeutic interventions with greater risks of adverse events, and care which maintains or improves capacity to perform work. Efforts towards self-care recommendations should be documented. And as always, you are trying to engage the patient throughout your care to take better care of themselves to avoid these issues from continuing to reoccur in the future. That patient who says, I get better with chiropractic, it really does help me, but I keep having to come back. The CCGPP guidelines address that. Under the general considerations, they say most acute pain, typically the result of an injury, micro or macro trauma, responds to a short course of conservative treatment, Table 3, which you saw a few slides ago. If effectively treated at this stage, patients often recover with full resolution of pain and function, although reoccurrences are common. So, we don't need to be apologetic for the fact that patients need to come back for chiropractic care. They do, because in chiropractic, it's not like you can take a brace and open up the spine and put a brace on the spine that keeps the spine stable. The patient is going to have issues, environmental issues. It could be anything from a terrible mattress or a bad pillow to psychosocial issues, stress in their lives, financial stress, work stress, that is going to cause their backs and their necks, or whatever the issue is with the musculoskeletal system, from becoming aggravated. And you cannot prevent those. So you should not apologize for the fact that a patient may need to come back, and you can even tell them that they probably will, and it's okay. But you can also tell them that if they come back to you before the pain gets so intense and before the disability becomes so great that you have to put them on another acute care plan, that they will be able to come back periodically, have a tune-up, and be able to move forward, and that they should never have to come back for a trial of care of 12 to 15 to 18 visits, as long as they take care of the problems while the problems are still small. If they have a reoccurrence, Medicare defines a reoccurrence as a return of symptoms of a previously treated condition that has been quiescent for 30 or more days. This may require the reinstitution of therapy. And at the end of the CCGPP guidelines, we're going to discuss this in a few minutes, there are these wonderful algorithms that will guide you to the correct treatment parameters depending on the patient's presentation. So one of the things that the CCGPP guidelines is it gives you the freedom that based on the science, okay, you can let the patients know that they may occasionally need to come in for a micro treatment plan or for a visit here and there, and then you can move them back to supportive care very quickly. So be sure that you're looking to do this as you build a strong cash-based maintenance practice. All right, as we move forward now. So we've been talking about documenting functional deficits and functional deficiencies and improvements, and how we begin to quantify these measurements of functional debilitation, functional disability, and improvements. And there are a number of outcome measurement tools that you can use to set a baseline for your patient, for your incoming patient, of their functional status, whether they have disability or whether they just have minor functional pain. And some of the recommended measurement tools that are recommended by the CCGPP guidelines are pain scales, such as the visual analog scale and numeric rating scale on a 1 to 10, pain diagrams that allow the patient to demonstrate the location and character of their symptoms, validated ADL measures such as revised Oswestry Back Disability Index. They have it for the back, and they also have it for the neck. Roland Morris Back Disability Index, RAND 36, and Bournemouth Disability Questionnaires. Increases in home and leisure activities, documentation of the increases in home and leisure activities in addition to increases in exercise capacity, increases in work capacity, or decreases in prior work restrictions, as well as improvements in validated functional capacity testing, such as lifting capacity, strength, flexibility, and endurance. You know, as a compliance specialist, one of the fastest growing divisions of my company is the documentation compliance audits that I'm doing very extensively for chiropractors and medical doctors, for that matter, throughout the United States. And when you implement a compliance program in your organization, one of the key elements of a compliance program is to conduct internal auditing and monitoring of your billing practices and of your documentation. And so, you know, I have a motto, and that is, let me audit you before they do. And so it's wonderful to see many doctors nowadays taking a much more proactive approach to their documentation and asking me or someone similar to myself who also, you know, there are other compliance gurus out there in the chiropractic profession beside myself, obviously, who will look at your documentation and who will advise you on areas of risk within your documentation. And so what I see, and again, this is not out of any research, although I could give you the research from Medicare on what they see as the most common documentation deficiencies, and you're going to see this as well, but I see it as well, is number one, the absence of a written treatment plan. So we look at a chiropractor's case and how many times they've treated a patient, and there is no treatment plan within the documentation at all. The absence of a baseline functional assessment, some type of of a starting point to measure that patient's disability and function and their ADLs. There's no mention of what it is a patient is not able to do as a result of the back pain they have. They can't golf, they can't lift their grandkids, they can't lift groceries out of the trunk of the car. Those things aren't being documented. So without those issues and those types of items being documented, it doesn't give us a starting point, and then it doesn't give us the ability to set treatment goals because we have nothing to measure it against. And so the absence of treatment goals is another common documentation deficiency that I see in chiropractic offices. What do we expect to accomplish with this patient's treatment? So things should be documented like this treatment will allow patients to play golf again. You know, they're retired and they live in Sun City, Florida, and they like to golf 3 times a week. And this patient hasn't been able to golf in 3 months because of debilitating back pain. That is a baseline that you can use to measure the outcomes, because now in future treatments, you can be asking the patient, well, you know, have you tried to go out and swing a golf club? And they'll say, yeah, you know, I was able to get out on the driving range for 10 minutes, which is a lot more than I was able to do 2 months ago. You need to document that, okay? Because that is showing that the treatment plan is working. Improvement in the Oswestry Disability Index scores by the next evaluation. So if you use the ODI as the baseline for the functional assessment, then at the next re-exam, you do it again and see if the scores are higher, okay? Remember also that treatment goals are really good for your practice because it helps to keep a patient compliant. If you set treatment goals for your patient and you set a treatment plan and it's in writing and you explain it to the patient, and you know, in management we call this the written report of findings, okay, but it has far-reaching ramifications besides just, you know, a nice glossy brochure that you give to the patient. Treatment goals keep the patient compliant because you can refer back to those goals at every single visit, and you can say, gosh, Joe, you remember, you know, I've seen you 4 times, and you remember when you first came in and you couldn't even raise your leg, you know, and bend your knee fully, and now look at you, you know, we're able to raise your leg up into your chest with no problem whatsoever. Look at that. And the patients are encouraged, and they're encouraged to keep coming back for treatment even though they're out of pain. You know, I hear chiropractors say this a lot, and they will tell their patients, and it's very common verbiage in report of findings. You'll tell your patient, the pain is the last thing to show up and the first thing to go after we treat you. And many chiropractors will boast to me that I can get a patient out of pain in 2 to 3 visits, and I believe it. You know, I mean, I'm like 100% believe in chiropractic. Okay, you know, I go see the chiropractor, and if I have back pain, I go see them in 1 visit. I'm done. I'm great. You know, I mean, I'm thrilled, and I think chiropractic is absolutely wonderful. But the problem is that for those of you who take that philosophy, you have to be careful, because if you know, pain is the last thing to show up and the first thing to go, but you're still down the line at visit 12 and 18 and 20 and 24 and moving forward there, and your primary diagnosis codes are still pain codes, then you're setting yourself up for a high risk of audit and recoupment, because eventually under audit, if that primary diagnosis code is cervicalgia and you're at visit 30, you're going to have the auditors are going to have a feast with your treatment plans and with your documentation. So be sure that that you have a written treatment plan, that you've set treatment goals, and that you're using in your daily notes, you're referring back to that treatment plan and treatment goals in some manner, whether it is, you know, simply stating in your documentation, patient is on schedule to fulfill the goals in the original treatment plan. You know, there's been no delay in the patient's progress. The patient is progressing as expected. should complete treatment plan on schedule. Things like that should be documented through the duration of the of the trial of care. So under the treatment recommendations, another thing that is discussed in the CCGPP guidelines is how physical modalities and physical therapy can be incorporated into the treatment recommendations. Basically, under the CCGPP guidelines, the statement is that an initial course of chiropractic treatment typically includes one or more passive, i.e. non-exercise manual therapeutic procedures. For example, manual spinal manipulation or mobilization and physiotherapeutic modalities for pain reduction, in addition to patient education designed to reassure and instill optimal strategies for independent management. It goes on to say, though, although the evidence review does not generally support the use of therapeutic modalities in isolation, their use as a part of a passive to active care multimodal approach to low back pain management may be warranted based on clinician judgment and patient preferences. And then it goes on to say that because of the scarcity of definitive evidence, lumbar supports are not recommended for routine use, but there may be some utility in both acute and chronic conditions based on clinician judgment, patient presentation, and preferences. So the question I have is, do you have a passive to active care multimodality approach to low back pain management? Now, I have nothing negative to say about chiropractors who believe that the chiropractic adjustment is the only treatment that should be rendered to a chiropractic patient. That is a long-standing and valid philosophy. Patients respond extremely well to adjustments only. And for those doctors who are straight chiropractors, this may not be something that you would want to recommend, that you would want to incorporate as part of the CCGPP guidelines. But be aware that when you're looking at it from the scientific standpoint, and you're looking at it from, if you're wanting to gain more acceptance within the medical community, okay, they are going to be looking at the multimodal approach of spinal manipulations moving into therapy and rehab as the most logical course of treatment. And the other thing is that insurance carriers generally look very favorably on this type of treatment protocol, and active care also has a higher reimbursement rate than passive care. So be aware of that. I want to talk to you about one area of chiropractic that I feel as a profession, and again, I'm not speaking to everybody, but I will say that is probably the majority of chiropractors in the United States fail miserably at re-exams and re-evaluations. I'm just saying. I have literally discussed this with hundreds and hundreds of chiropractors over my career, and the majority of them will admit to the fact that they do a poor job at re-exams. And re-exams, to me, are one of the key elements of success, not only successful management of an active treatment of your patient, but also the key element of the successful transition of your patient from active care to supportive care or maintenance care. And so, and the CCGPP guidelines are very clear about this. They state that after an initial course of treatment has been concluded, a detailed or focused reevaluation should be performed. The purpose of the reeval is to determine whether the patient has made clinically meaningful improvement. A determination of the necessity for additional treatment should be based on the response of the initial trial of care and likelihood that additional gains can be achieved. And if at that point at the re-exam that the likelihood that additional gains cannot be achieved, you're going to, at that point, consult with the patient and let them know that they need to move into supportive care. As patients begin to plateau in their response to treatment, further care should be tapered or discontinued depending on the presentation. And it goes on to say that when a patient reaches complete or partial resolution of their condition and all reasonable treatment and diagnostic studies have been provided, then this should be considered a final plateau MTB, maximum therapeutic benefit. It's also known MMI, maximum medical improvement. The DC should then perform a final examination, typically following a trial of therapeutic withdrawal, to verify that MTB has been achieved and provide any necessary patient education and instructions in effective future self-management and or the possible need for future chiropractic care to retain the benefits achieved. If you're not, folks, if you're not getting your patients to the re-exam, you're missing all of this. And I'm just saying, the doctors that I know that get this, that get their patients to the re-exam, and that do a great job with the re-exam and correlate it from the original treatment plan as far as the management of the treatment, the fact that the patient has reached their goals, their treatment goals, and it gives you a time to celebrate with your patients the fact that you have reached these treatment goals. Then you can discuss with them the exciting idea that they don't have to go through this again if they take care of themselves and if they come back for periodic treatments from time to time. And so the re-exam allows you to do all of that. So let me ask you this question. If you had 50 new patients last month, I want you to go back to your office and I want you to pull some stats. Do a code usage report for last month and look at how many re-exams you coded. Okay? And you know what? I hear of doctors, they'll give me a lot of excuses as to why they don't do re-exams. And one of them is, well, patients don't want to pay for a re-exam. Well, it doesn't matter. The patients will pay for them. Don't give them away. Don't do the re-exams and not document it or give it away. Charge for a re-exam. It's okay. I'm just saying chiropractic is the best deal in town for most patients. If they were to go to I have an HMO. Every time I go see my doctor, it's a $40 copay under my HMO. And I have to go to my doctor every single time I need a referral to a specialist. So even if I go see my chiropractor, I have to go see my doctor first. She refers me to a specialist. It costs me $40 just to get the referral, And so if a patient has to have a re-exam, they have to have a re-exam. Don't be afraid to do these. And make sure that you have them built into the patient's schedule of care as to when you're going to do that re-exam and the reevaluation. Another thing that the guidelines gives you is informed consent, and you have the actual wording for informed consent for low back within the guidelines themselves. And it basically says that a 2010 review concluded that serious adverse effects were no more than 1 per million patients visits for lumbar spine manipulation. Okay. And it says that another review found that the risk for major adverse events with manual therapy is low, but many experienced minor to moderate short-lived adverse events after treatment. So how many of you have ever had a patient who calls up after the first or second visit and cancels all their appointments because they were in pain after their appointment? The pain didn't subside. It may have even gotten a little worse, which could be expected depending on the patient. But you didn't give them this informed consent, and you didn't explain to them that while a chiropractic adjustment may make them feel immediately better, it could also make them feel worse before they feel better. And so they call their doctor, and their doctor says, well, come see me, I'll give you some drugs, and don't go back to see the chiropractor, because that chiropractor is doing you more harm than good, because you did not do your due diligence in informed consent. The guidelines give you the wording for the informed consent, so make sure that you are doing informed consent on your patient and communicating both the benefits and the risks of chiropractic as well. And I'm just saying, I've done informed consent, on patients, and I've talked to them about it, and I say, look, when you look at our informed consent, and then you look at the back of a drug, and you see all of the risks and side effects, or even if you watch TV and you see a commercial for this new drug that cures, everything under the sun, and then they spend half the commercial telling you what the side effects of that drug is. I'm not really convinced. I'm not really excited about taking that drug. But if I'm telling you that chiropractic care, serious adverse effects is 1 in a million, I think those are pretty good odds. I'm going to take my chance on that. So anyway, make sure that you use the CCGPP guidelines to deliver a good informed consent on your patient. Other helpful elements of the CCGPP guidelines are, as I mentioned earlier in this presentation, are the table of contraindications to treatment of low back conditions. So there are 2 pages of them, and you can use that as a guide to refer patients out in the event that they meet one of these guidelines for contraindication of chiropractic treatment. So, and it may be that the patient could have some other type of treatment, maybe massage therapy, but not dynamic thrust. And so you would want to know, obviously as a chiropractor, I imagine that you know what these contraindications are, but it would be a good idea to review these from time to time because, you may have patients who meet these guidelines that you can then refer out and begin to develop a good back and forth referral base between yourself and the medical community. And then finally, I love these algorithms. They really, really help doctors of chiropractic with managing the different scenario of patient with low back pain that may come to see you in your office, and then what to do, what the next steps are. And so, the general algorithm then is followed by the acute care algorithm and then the chronic care algorithm. And I have the general algorithm displayed here. The acute care and the chronic care algorithm are within your handouts of the actual guideline. My recommendation would be, print them and laminate them. Have those algorithms front and center where you can use them to help you with your management of patients with low back pain. So, you have a patient that presents with low back pain. It's a new patient. And so you're going to perform a new patient evaluation on them. And then if the pain is of 3 months duration or more, if they've had this problem for more than 3 months, you're going to go to the chronic care algorithm. If it's less than 3 months, you're going to go to the acute care algorithm, and so on and so forth. So these algorithms are extremely beneficial to you. And finally, I want you to remember, as I mentioned in the early part of the presentation, that the CCGPP guidelines are very clear about not using them as a one-size-fits-all limit or visit limit on low back pain treatment, okay? It's not just 12 visits or 24 visits or 18 visits. It's based on your clinical judgment and your guidelines. Now, and you can see here that what it says is that, for example, in one area of the CCGPP guidelines, it says that thus it is important to consider this guidelines recommendations for visit frequency as ranges rather than specific numbers. And then on page 18 it says, therefore it is important to view practice guidelines in this context, and that a one-size-fits-all approach will not fit in all patients, okay? So be aware of that. So in conclusion, I just want you to remember that these guidelines are going to arm you with powerful tools for your practice to treat and manage patients with low back conditions and ultimately improve profitability in your practice. Because I know, we're all healers here, right? But we also have to make a living. And using guidelines such as the CCGPP guidelines and the scientific evidence behind these guidelines to manage your patients and to co-manage your patients will give you better patient outcomes, which will then lead to a more compliant and satisfied patient, and as such, in conclusion, a stronger referral base. Using the accepted and adopted scientific approaches to patient care increases your credibility and acceptance within the mainstream medical profession. And it will add a huge armor of protection on you against malpractice claims. If you're following a scientific guideline for treatment parameters, then you don't have to worry about those patients that and you're documenting correctly and you're giving the correct informed consent, then, if a patient gets mad about their bill and threatens to sue you, you don't have to worry because you've been following a scientific document for management of that patient condition. It also provides powerful tools for you to maximize insurance reimbursements and appeal medical necessity denials. I love doctors that use these guidelines as a biller because if I have a claim that gets denied for medical necessity and I ask the doctor to send me the notes so I can appeal the claim, and the notes don't have any mention of functional improvement, no treatment plan, no treatment goals, and the denial came at the 25th visit, I'm going to probably just send it back to the doctor and tell them that they're wasting their time and money in appealing this claim because there is no insurance company that is going to go ahead and pay that claim, even if you do send the notes, because you did not have a comprehensive documentation to support the medical necessity for that claim based on scientific evidence and guidelines. And finally, it does help you with the very challenging task in chiropractic offices of managing patients who have chronic low back pain. So I do want to thank you for attending today, and I'm just going to spend a few minutes talking to you a little bit more about Clinical Compass and the Council on Chiropractic Guidelines and Practice Parameters. They are a 501c3 nonprofit organization. And honestly, talking with Dr. Jay Greenstein, who is the president director of the CCGPP at this point, it's like he said, we rely 100% on donations, and I totally get that. So, if they're supplying you with this incredible research to help you keep the credibility of your practices, to grow your practices, I would recommend you to give something back to them. And they accept any donation. They do have a President's Club membership, which is $84 a month, or a one-time donation of $1,000. They're also working in conjunction with Performance Health right now on opioid research. If you donate either $200 or $350 toward that project, you'll receive a free product display, a counter display, or a tower display, depending on your level of donation of BioFreeze products. So that's really cool. If you're interested in doing that, you can go to clinicalcompass.org/donate and donate what you can towards this wonderful organization. And my commitment as the founder and president of Gold Star Medical is I have a commitment to the Virginia Chiropractic Association, as they have been so kind to invite me to come and speak for them at these webinars, and then finally in May at the upcoming spring meeting, the conference. I'm also a President's Club member of the CCGPP, so I donate monthly. But in addition to that, all of the financial proceeds from this webinar and the other 2 webinars that I'll be doing are going to be distributed 100% between the Virginia Chiropractic Association and Clinical Compass. And for every new client of Gold Star Medical who, if you are listening to this webinar and you decide that, hey, maybe I would like to employ you as our billing company, or I'd like to have you do some consulting for us, for any VCA member who signs up with Gold Star, I will donate $50 to the VCA and $50 to Clinical Compass for every new sign up. So, I'd encourage you to tell your friends and colleagues about this webinar series. It's open to members and non-members. I believe the non-member price is $45 and the member price is $35. Our next webinar is going to be February 14th. And then February 27th. So every 2 weeks, we're going to have a webinar. And if you want to register for the next 2, go to the vca.org to register. And remember that this webinar has been recorded and will be available through the VCA. So you can contact the VCA for the recording of this webinar. So I want to thank you so much for your attendance. I'm going to stop the recording now, and we'll be answering any questions that you might have. So let me just take a second to stop the recording. And I appreciate all of you being here this afternoon.